Okay, guys, welcome to our discussion of diagnosis and assessment. We're inching ever closer to actually talking about specific disorders, but this is all the preliminary information you need to make sense of those later discussions. So let's start just by thinking about what it means to diagnose somebody, because that word diagnosis often has a negative connotation, and and I want to kind of tease that apart a little bit. And the first thing is, like you've heard me say before, when we're talking about symptoms, I'm going to try always to bring us back to a reminder that symptoms are only symptoms once we decide they belong to a disorder. But before that, they are simply experiences somebody is having or behaviors that they're engaging in. Essentially, diagnosis is the act of making observations about the experiences somebody's having or the behaviors they're engaging in, and seeing if they fit a pattern that we typically label with a specific diagnosis. And sometimes people seek out diagnosis. Somebody else um, uh, is the motivation for another individual's diagnosis. So a general practitioner, family doctor, who simply makes the observation during a physical exam that something might be going on psychologically, or a family member who does that. And sometimes people are really clear on what behaviors and experiences they're concerned about and would like information about diagnosis. And so the example I give here in the slide is feeling sad. Somebody might come in and say, my mood is just sad all of the time. And then when I start asking about things like concentration and attention and memory, they are surprised to see that I'm wanting to fit that in, or to see if it fits in with a diagnosis of depression that goes along with that feeling sad. And for many people who come to me for the first time, a diagnosis is actually a relief, that they're glad to have a name to give what the experiences and behaviors that they've been engaged in, and that's the first step towards a plan to making things better. And there's times when people are immensely relieved. So, for example, often if somebody comes in with experiences and behaviors that I see as being part of panic disorder, often people will say, I thought I was losing my mind, whatever that means to them. And we get to have a conversation about how the treatment for panic disorder is often fairly quick, that usually, within a 3-month period, people have significant relief from panic symptoms when we engage in treatment. And so this is really good news to them, that there's something as a label, that's a treatable label, right? It can be a more negative thing if the news that comes along in terms of prognosis is more difficult. So disorders that we expect to be something the person always needs to think about to one degree or another, like bipolar disorder or schizophrenia, might be a less uplifting diagnosis. Sorry about that. We will talk some, I want you to be thinking some about the issues of reliability and validity having to do with diagnosis, and we'll talk a little bit in a couple of moments about the DSM, and that we are now the 5th version of the DSM. And that those versions mostly are about trying to increase reliability and validity with each change. Reliability is always about consistency, and so inter-rater reliability is the one we think about most with diagnosis. And this is essentially that if you come into my office and I see a set of behaviors and experiences, and I see that as generalized anxiety, that if there's good inter-rater reliability of the system we're using, in this case the DSM, to make decisions, then 2 weeks later, if you go see somebody else and tell them about the same behaviors and experiences, they also should arrive at a diagnosis of generalized anxiety disorder if we're both doing that correctly. If the DSM makes it hard to do that, where there's something about how it's constructed, about the symptoms, about how they're explained, that makes it easy for me to interpret one way and somebody else to interpret it a different way, then we would say that there was poor inter-rater reliability. And we'll talk at the end on the second lecture that we'll do here in this chapter about different assessments, and we'll talk about reliability as well as validity for different assessment approaches. Validity is about accuracy, and so this is about essentially whether the DSM or another diagnostic tool is measuring all parts of a disorder, or is it missing some pieces? Is it using experiences and behaviors that actually belong and to be connected with that diagnosis? And does it predict something meaningful? Does it predict prognosis correctly? Does it predict response to treatment correctly? And both of these things are important when we have a diagnostic tool. And so we've mentioned the Diagnostic and Statistical Manual, the DSM, which is in its 5th version. And you guys will be thinking about this a lot in your small groups. And, you know, as I said before, each revision really is, the main effort is to increase reliability and validity. And then part of doing that is to make the categories more meaningful and distinct from each other. Where there's great overlap between categories of disorder, then we're going to muddy the waters, and we're going to have less good inter-rater reliability and certainly less validity or accuracy. The other thing we're always trying to do is make our criteria for diagnosis more objective, right? Subjective things are open to my interpretation, objective things are more factual. So saying somebody has been feeling sad for a significant period of time leaves it up to me to decide what's significant. Whereas saying somebody has to be feeling sad for at least 2 weeks is objective, right? I get to just figure out whether that's been true for at least 2 weeks. And that increases reliability and increases validity. We also want to make sure that that cultural issues are paid attention to. We started talking about cultural issues a little bit in past chapters, but you know, the idea that what is a violation of social norms will be different in different cultures, and as a therapist, being aware that there are differences. I don't always need to, there's no way for me to know what's true for all things in every culture, but it does mean that I have to always be aware that my cultural assumptions may not be accurate for somebody who hasn't been living in the culture or cultural niche that I live in. And so that awareness is really important. And we also have to worry that if we have too many diagnostic categories, that we may actually be fine-tuning things too much, and they actually may be multiple categories might be actually speaking to the same thing. And then that's when we suspect that's the case, then the next version will collapse disorders down. We're going to talk in the personality disorders chapter about the fact that that is true for sure about the personality disorders. The ability to distinguish between histrionic personality disorder and borderline personality disorder is too difficult. There's too much overlap. We should be collapsing those 10 disorders down probably to 3 or 4 disorders. But we'll talk about that more in that chapter. And so the subjective decision making is going to be our greatest downfall, right? And sometimes even with a really good system, we have that happen. So the example I have here is a client I always think about when I talk about this, and she came to me in her, I want to say she must have been in her late 20s or almost 30, and had really been struggling in some fundamental ways for about 5 or 6 years when I met her. She had gone to graduate school, and at the end of that graduate degree, where she had been living out of state from her family, kind of collapsed and really couldn't focus on the jobs that she had, really couldn't function, and she couldn't hold a job, and she wound up coming home because she couldn't hold a job and couldn't keep her living situation going. In that other state she was living in, she had gone to see somebody who specialized in attention and concentration issues, and when she presented with attentional difficulties, she was diagnosed with ADD, attention deficit disorder, and given the treatment for that, which is mostly stimulant medication. And not only didn't it make things better, but it made things worse. She felt more anxious and less comfortable. And then she avoided treatment for about 5 years because she just thought the treatment couldn't help her. And when she came to see me, my interpretation of her symptoms was that she was significantly depressed, and also struggled with social anxiety and generalized anxiety. And that poor concentration, that difficulty concentrating, the difficulty with attention, both of those things, while they may be symptoms for attention deficit, are also symptoms for depression, and can be symptoms when somebody is struggling with generalized or social anxiety, when they're flustered in social situations, for example. Often it looks like they can't track closely what people are saying because they're so distracted by their own anxiety. And so I saw the attention symptoms really as part of that major depressive episode and her anxiety, and proceeded with treatment that way. But it took a really long time to convince her to engage in treatment for depression and anxiety, because she had decided that she must have ADD and just not be good at getting treated. But I've been seeing her on and off for 5 or 6 years now. She's doing very well, with therapy we did and with the medication for anxiety and depression. And so it appears that my interpretation was correct, but it doesn't mean my interpretation will always be correct. That there are places when there is just a subjective sense of where does this fit. So we're going to pause there, and we'll have a second lecture that talks about these assessment tools.